Well, welcome back, everybody. Hope you had a little break. What we're going to do now is show you an impact video. We saw earlier some of lovely testimonials from some of our graduates. We're now going to have a look at the impact that we've been making, and then we're going to move straight into the panel discussion.
Australia needs more rural doctors. According to the latest data, rural and regional health is suffering, with poorer health outcomes and continued lack of access to healthcare services. Australia has plenty of doctors, but they are mainly staying in the big cities. So how do we close the gap between city and rural health? The James Cook University Medical School was created 20 years ago to do just that. Since then, JCU has become Australia's most successful university in delivering a fit-for-purpose regional medical workforce. We are Australia's only university that offers medical training from undergraduate to specialisation. Our students are rurally focused, and they're given more rural experience. This means our graduate doctors are more likely to go rural and stay rural. In fact, this year alone, more than 1,000 of our graduates and GP fellows worked in regional, rural and remote communities. We've come a long way, but the job isn't done. We will continue to advocate for regional, rural and remote communities to build a future where they can be confident their health will be looked after. Because we believe that no matter where you are in Australia, everyone deserves a doctor.
Well, thank you. That's a very fitting introduction to our panel. And just before I introduce formally the panel members and start with the questions, I would also like to acknowledge the many people who are online who we can't see, and they include people like Bob Porter and Alan Nimmo, who are part of the very big lift of the medical school and has led to its very significant success. So moving straight then onto the panel, I'm delighted to welcome the following people. I think they're all known to all of us. We'll just go through it. We've got the Honourable Mark Coulton, who's the MP for Parks and Minister for Regional Health. We've got our very own Professor Ian Runsky, there he is, who's now I can't say it, Ian, Professor and the Chair of the Tropical Australian Academic Health Centre. We've got Professor Ruth Stewart, who's our National Rural Health Commissioner. We've got Gillian Farmer, whose video is now working, jolly good, Office of the DG of Queensland Health, and Professor Richard Murray, who was talking earlier. We've had lots, as you know, lots of questions that were submitted, and I hope that you've had a chance to have a look at them. We've also got several that have come through. And I wonder, Minister Coulton, if we might start with you. You will see there were some couple of very pointed questions around legislation and government plans. So perhaps I'll just hand over to you, if that's okay.
Well, thank you very much. And it's great to be here. I'm actually in my office in Canberra, but I'm looking out the window because this afternoon I get to go home. It's very exciting. And you know, I know there's been some changes, and so congratulations on Professor Murray in your new role, and Professor Ronsky for the job that you've done, and certainly great. So it's your 20th anniversary. So I did a bit of research. That's a porcelain anniversary. I thought, what sort of gifts would you give doctors that are porcelain? And none of them are really the sort of ones you want to give as a gift for an anniversary. So anyway, happy porcelain anniversary. Look, it's a great milestone, and as I get around the countryside and I meet with people, the number of communities that are being serviced, lives that are changed, lives that are saved by graduates from JCU is quite noticeable, and you can actually see, you know, if you pin on a map where we're having sort of more rural health issues and less rural health issues. Where we're having less rural health issues is where the JCU graduates are. So that's a real testament to to the success of the schools, both in medicine and dentistry, and also the ability to recruit and train exactly the right people to take up the challenges of going to regional Australia. So well done. Just briefly, there is a couple of questions, but one of them is we probably are more regulations changing than legislation. Quite often the legislation's broad enough to carry a lot. I'll give you an example of, we're doing some trials in New South Wales, sort of joint funded trials between the state government, the Commonwealth, and so you might have to change regulations, around the payment models of what's allowed and get exemptions to do those. And so that's the space we work in regulatory. But, as you know, health is all about relationships. And so what we are trying to do is have the flexibility as a federal government to recognise what's working in a certain community and then go in and back that model. And so rather than the federal government knows all, and here's our rural health policy, our policies are more in line to encourage what we have. But having said that, we are obviously steering in a direction with the generalist pathway. We're recognising that GP training as a specialty is not as popular as it should be. How we might encourage students to make that decision. My personal belief is that we've got to change the dialogue and stop talking about a rural health crisis, start talking about a rural health opportunity. And so I think if there's a silver lining in COVID, it is that people are now looking to regional Australia as a safe place. I'll put my regional communications hat on for 10 seconds and say they've worked out that you can work remotely and be associated with a capital city. And that technology is also changing the dynamics of medicine. Telehealth was one of the great success stories of the pandemic, with about 34 or 5 million consultations now via telehealth, many of them from regional Australia. And so the younger crop of medical graduates coming through, it'll be second nature to them to be using that technology. And so the other focus, and I won't go for much longer because I know you've got very eminent people on the panel as well, but looking at multidisciplinary teams, understanding that it's no good just putting a GP in a community if they're not backed up by a fully qualified nursing team with the backup of allied health. We're excited about the start of the allied health generalist training program that does recognise that you do need a broader range of skills in allied health as you do with general practice if you're going to work in the regional areas. And so we have funded a few trials in the budget. Basically, they're very different to each other, just to see what works and what doesn't. But I think I'm very excited. I think with regional Australia looking to be a kinder, safer place to be, I think some of the obstacles that we've had in encouraging people to go bush are going to be less. But obviously, backed up by a training program and the work that you've done as an RTO as well. I think that sort of really has been what's given your graduates that follow on the support right.
What we call the double dip, Minister. The double.
Yeah. Very good. So in short, congratulations, and happy to take part. But I could prattle off a whole heap of millions of dollars and figures, but I really just wanted to focus that we recognise the challenges in regional Australia. I think there's great opportunities, and I think we're in the process of turning it around. And I think your organisation, your graduates are leading the way.
Thank you so much for those very kind opening remarks. And yes, the difference between regulation and legislation, important, aren't they? We often
Yes.
trip over regulation rather than the policy. I wonder, this is a nice segue, Ian Ronsky, to you. As you know, we have Peter Lindsay online, and a very important person in the setup of the medical school. And he set us a very pointed question for the panel, which was, one of the rationales in 1988 for the establishment of JCU was that there was a maldistribution of doctors, specialists, and medical services in Queensland in favour of the southeast corner. And his question, which I'm giving to you, Ian, is how successful has the JCU Medical School been in addressing the maldistribution and the poorer standards of health in the north?
Well, recognise Peter Lindsay's role in that torrid campaign. It certainly was the aim to improve quality and access to health services. I think Richard addressed this in some detail early on. But for those who weren't around, when I turned up in Townsville in 1992, Townsville Hospital had just been through a very difficult review around quality in psychiatric services. It was infamous for it. And the health system broadly was reeling. And it wasn't just that the primary care side of it was struggling to survive. The hospital system was falling apart. Look at it now. Townsville University Hospital. I mean, it's the most important hospital outside Brisbane. Cairns Hospital is well on the way to becoming a university hospital in a real sense, like level 6 services, integrated activities with university, critical roles in shaping the future workforce. It's really hard to go around a lot of Queensland, but even the Northern Territory and New South Wales, without running integration JCU graduates in rural areas, and not just in medicine. I mean, some of the more difficult things that Maggie, my wife, once found was when you're trying to get a prescription filled for something that was embarrassing. It was almost impossible to go to a pharmacy without having an ex-JCU student dispensing it. And because I used to travel a lot, I took one of those prescriptions to a bit of regional New South Wales. And that was a JCU pharmacy graduate. So the landscape is dramatically different. Now, we haven't done everything, and there's lots more to do, but JCU graduates contribute way over what you'd expect on the numbers, not only to boots on the ground, but also the policy settings. These were all contentious issues. Was it just one of nature's laws that doctors only worked in urban centres? Like, I was looking through the Old Testament and couldn't find any reference to that. So these are human-derived policy reactions, and inattention to the policy settings has allowed this to occur. And now JCU has got to the situation where it does have the capacity to play a global role in policy settings. And a lot of that goes back to the sort of lively discussions I remember, and Bob Porter is, I hope Bob Porter is there, who was the planning dean, who brought together a lot of the things that we implemented. There was Alan Nimmo, who focused on the undergraduate curriculum. We actually had a debate on whether we should include science teaching and anatomy back in medical curriculum, because they disappeared in the 90s, drove the College of Surgeons crazy. So we really did lead the way. Richard Hayes implemented fabulous ideas, particularly in the clinical training area, and it was revolutionary. So,
so Ian, what's the scorecard out of 10, do you reckon?
whilst we just focus on Australia, 8.
Good.
But if we actually take up our natural role in the West Pacific and the region, maybe 9. But we haven't yet done that.
Mm-hmm. Thank you so much. We'll come back to you in a bit. I wonder, Jolanne, if I could come to you, because I think that's quite a nice segue. We've had, you know, sort of a Commonwealth view and then the view of how JCU Med has managed. We had, as you know, several questions which came into you really. And I suppose the one that's we've been talking about recently in other forums is how to better integrate state, Queensland Health, with Commonwealth and private, which as you know, in outside of the city, it's all the same people really, usually working across multiple, trying to work across multiple sites, but often falling over all sorts of barriers as to how to make that work well.
Thanks very much. I think that one of the things that stands out to me now, having been out of Australia for so long and then returning, is that our funding model is designed to deliver the results that it delivers. And traveling the world, I've really seen how much a funding model drives the model of care. In those countries where you are paid a per diem rate for treating a patient, the length of stay in a hospital is astronomical, 10 days for an appendectomy. In those countries that pay you for treating the condition and a fixed fee, you're out of hospital same day or next day. And I think one of the real challenges for us, and without necessarily, expressing a view about what the right solution is, that we have to robustly examine what our funding model of cleaving primary care away from the funding base of hospitals, and those rules that were originally designed to protect integrity and prevent double dipping and ensure that each sector was carrying an appropriate part of the burden. I don't feel that our funding model can take us forward into the second half of the 21st century. I feel that we need to really re-examine that. Meantime, I think that one of my favourite maxims at the moment, which I will share with you because it's very apt, I think, if you're not at the table, you're on the menu. And so I think that we have to make sure, and this is where I'm really excited as a former GP to be in the position that I'm in now, because even though that is former, I can bring a general practice perspective to all of the decisions that I'm involved in Queensland Health. And I do think that I would encourage ambition within JCU and the other medical schools that are seeing themselves as feeding rural areas to feed further, to seek to develop up people who understand health systems and can step into leadership roles in the health systems to nurture and grow them. I was just at a function last night where someone told me that one of the things of commentary about me is that how does a GP from Chermside become the medical director of the UN and then a deputy director general in Queensland Health? How does that happen? How do we learn from my journey? How do we find other journeys and make sure that GPs don't, and rural generalists and those of us who sit normally outside the corridors of power are in there at the table, influencing and making the decisions. So we have to have people at the table, primary care at the table. And I think we also need to develop a shared understanding of what that term primary care means, because a lot of GPs, when they say primary care, mean general practice. But our allied health colleagues, our nursing colleagues, do not think that GPs represent the totality of primary care. And I have to say, having worked outside Australia, I agree with them. GPs are not the totality of primary care, and if we try to be that, we will fail because we can never possibly meet all of the demand. So to come back to the core of the question, how are health organisations working towards better integration rather than the philosophical ramble I've just given you? What we're currently really doing is really trying to find ways to partner, and that is hard because no one entity speaks for private general practice, and it is not a unified voice. And so we engage, and we can end up with whiplash as we receive these widely disparate views from what ought to be aligned groups. Now, I don't think that there's complete cohesion of opinion, for example, in surgery. I don't think there is complete cohesion in medicine. But there does seem to be something about general practice that has led itself to being an extremely broad church. It's the nature of the beast, but therefore difficult to present a single cohesive direction. So what we're doing is attempting that dialogue. We are engaging with the public health, the PHNs, with the primary health networks. And in the work that Queensland Health has been contemplating around reform, one of the key things that we're looking at is building a much better interface with primary health. Now, that work hasn't started yet, but for example, we do have a GP who's now working on some of the reform group recommendations. My division, Clinical Excellence Queensland, has been working extensively with general practice to integrate referral pathways and to partner with them and work out how we get patients moving seamlessly between the sectors, because that ain't happening at the moment. There are big barriers moving from general practice into the state public health system, and there are big barriers to getting people back out. We have to solve that. So it's conversation, it's dialogue, it's generating respect, getting the right people walking the corridors of power, not just in advocacy, but in decision-making roles, and being willing to re-examine funding models. I think it's a whole complex package.
Thank you. Fascinating insights, and I will never forget that analogy. And with your permission, I'm going to use it widely. It resonates in the rural space.
Minister, I bet it does.
Yeah. Ruth, I'll come to you in a minute. Mr. Coulton, and I know you're on mute, so I'm going to save you from one of the phrases of the year, you're on mute, and ask you, you know, there's some real challenges in what Gillian has said, isn't it? And that insight that it's funding models that need re-examining is it sort of speaks to what you were saying a little bit earlier, wasn't it? Yeah.
I just was Ruby next to me. I was saying we're going to have to go and meet with Gillian, because that's exactly the conversations we're having here. And you know, the issue we have with rural health is that we have communities with the highest level of health issues and the lowest propensity to pay. And so, you know, to steer the workforce into that area, we need to not only have the rewards of servicing and caring for a community that needs your professional assistance, but we also need to work on models that recognise that community has a higher level of need than other ones, and come up with models of funding so that it is not a disadvantage for a young person when they're choosing a career path to want to go into those places. And so, and you know, I was pleased that Queensland Health is talking with the PHNs, and certainly COVID has clipped our wings a bit as far as getting around, but that's, you know, if we're able to do that after Christmas, that's what I want to do, because we need to look at all the assets, that's human and physical asset, you know, in a community, and work out how we can service that community the best by what we've got there, and then where are the gaps and how do we fill in those gaps. And so my focus largely in my role as Regional Health Minister is in workforce. And so, you know, it's sort of, I tell people it's a bit like trying to water ski behind the Queen Mary. It takes a bit of, it's slow to react, but you need to be able to put these policies in place, and you know, I'll be long gone out of this job when the decisions that we are making today actually come to fruition. But I think I'm really heartened to think that we can work closely across jurisdictions, and you know, in a community where the hospital might be really well equipped, but the GP's the poor cousin at the other end of the street. How can we maybe correct that imbalance? And in some other parts of the country, it's the other way around, where the hospital struggles to keep staff and there's a well-equipped GP practice in town. So that's what we're looking at, yeah.
Yeah, thank you. And I'm glad that you want to meet with Gillian. I haven't told Richard Murray yet, but I actually want to work with her. I think we've got a question from the floor, John. Is that right, before we move to Ruth?
That's right, Peter. And Minister, this may well be best answered by you. Richard Murray spoke earlier about what JCU is doing to build medical workforce in regional areas. And Richard Hayes also spoke about the importance of connecting rural practitioners up with specialists via technology in order to facilitate quality healthcare delivery through communications, telephony services, data availability. The question that's been posed is, what work has been done and needs to be done around the delivery of adequate communication, data, telephony services in rural and remote areas and regional areas to support that type of healthcare delivery?
Look, I think what the pandemic has done is shown that our communication system in the bush is not as crap as led to be believed. I worked on a Sky Muster satellite connection for probably 10 weeks. All my Zoom, as a minister in the Australian government, all my phone calls, everything going through the satellite. We're constantly, we've got a policy now, regional connectivity program, where we are looking at bespoke methods of delivering higher capacity data into health precincts, into education precincts. And I think, the technology is going to be so important. We do have a bit of a risk at the moment. I don't know if anyone saw 60 Minutes last week, but there is a bit of a push to say that telehealth is going to be it's the sneaky way governments are going to replace workforce by iPads, and that's exactly the wrong message. It's going to be a great tool to have, but not a replacement. And so I think the idea that if you, one of the reasons I'm told, I'm very careful because I'm not a medical person and I'm dealing with professors and doctors and everyone on this call, so take that for what it is. But one of the things I'm told that is maybe inhibiting people to go into a more smaller community is the feeling of isolation. But if you know that the best assistance is right there where you can zoom in on a road accident victim or someone that's having a stroke or a mental health episode, and you can speak to the actual top of the field. And I launched with the New South Wales Minister telestroke services in Dubbo a couple of weeks ago, where you can talk to the best stroke specialists from the emergency room there. So I think it's going to be that is going to be the way that's going to link us up. But we do have, I'll take your point, we do have some more gaps to fill in communications. But I think what the COVID pandemic has done is shown that people can work from the bush not too bad.
Yeah, thank you. And the other thing I reckon it's shown us is that people do want human interaction, doesn't it? So really good to hear you say that. Telehealth is not a replacement, it's a tool, isn't it? Richard, I can see you taking notes, so we'll come to you in a minute. But Ruth, I wonder if we could, I know you've only been in your job 2 minutes, but we want to know, are you turning the tide? What's happening with rural generalism? And you saw the lots of questions that came through which were appropriate to you. So let's go to you, Ruth.
Okay, so if it was just me, I wouldn't be turning the tide, but I work with teams, multiple teams of inspirational people, including those gathered here. The model that we've been hearing this morning about the impact that James Cook University College of Medicine and Dentistry is having on the rural and remote medical workforce of Australia. And I'm able to talk to many people around Australia about that model. And one of the things that I have people say to me is, yeah, that's okay. But that's just in Queensland. Well, and I answer that with, well, actually, everywhere I go in Australia, I meet JCU graduates, particularly if that's rural Australia. And the other thing I say is those principles can be applied anywhere. And we have seen that Wollongong is also getting great results. It's about the dedication to the principle. So you can go through the motions of training, taking money for a rural clinical school, go through the motions, paying lip service to the quality of and needs of rural and remote communities, or you can do as JCU did, create a curriculum and a program that is absolutely designed around delivering graduates for rural and remote medicine. Now, those comments are focused on the undergrad, but we know that this is about the pipeline. It's not what can I do at the end of a training program to make a rural doctor. Well, you can't do anything right at the end because they are rusted on to whatever it is that they've decided to do during their course. But we know, that if you select preferentially for rural and remote oriented students, you give them early, well-supported and recurrent clinical placements in rural and remote areas, and you give them a clear line of sight to a job that they can be doing that is rewarding and recognised in rural and remote. And also, if you give them an explicit curriculum that describes what is needed in rural and remote and why it's needed, then people absolutely get it. Like, the results of James Cook University, College of Medicine and Dentistry absolutely illustrate that. Now, the other thing that we know is that when you apply those same principles to postgraduate training, vocational training, you also get outcomes. When you look at fellows at the Australian College of Rural and Remote Medicine, 87% of them are working in rural and remote Australia. Like, those are astounding figures. So don't tell me we can't do it. We can do it, and we just need more commitment. I think it was Richard Hayes who said earlier today that this is not one thing, it's a myriad, it's a complex, maybe it was Richard Murray actually, a complex web of decisions and structural changes that need to look, what many people see as proper medical training, but that have deeply embedded, really enmeshed in it, those principles of service to underserved communities. So I received, so the question, so that's the background. We can do this. We can train rural and remote doctors.
I'd never dream of telling you can't do something. I'd be far too scared to tell you.
Yeah, it's a bit of a red rag to a bull, actually. But what we know is that yes, we have pockets where we are producing rural doctors. Are we making a difference? Actually, I've just received a letter from the committee that oversees the awarding of the procedural grants. That's a by-college committee. I often hear people say, we no longer have the procedural rural doctors that we once did. They're disappearing. Actually, wrong. That committee that allocates the procedural training grants to rural and remote doctors has seen a stabilising of the numbers of doctors who are undertaking procedural work. The doctors who are doing that are increasingly female. They're still predominantly male, but the numbers of women in that group increase year by year. And it's really interesting when you look at the statistics held by the government about that group of doctors. They say that the numbers have stabilised. But when you go to the colleges and look at who they have on their books who are applying for those grants, which is sort of earlier data, it's a bit, further back, those numbers are increasing year on year. So yes, we are making a change. You just need to understand that this impact will be felt down the track, and we need to continue to focus on what we can do to make it change.
It's that ship analogy, isn't it, that Minister Coulton used? With the GP training piece, Minister, I've spoken about turning like one of those huge oil tankers. You know, it takes years before you're going to get it in the direction that you want to go. But thanks, Ruth. And Richard, we'll come to you in a minute. I just wanted to read one of the questions because I think this just really exemplifies what we're trying to do now in the next bit. As a surgical registrar that grew up in North Queensland and now work in Sydney, and has a keen interest in rural general surgery, where do you see the services provided by rural hospitals when there is a great emphasis in subspecialization? So this is someone who wants to come out, but can't see, exactly what you were saying, Ruth, can't see that path. So Richard, I wonder, Richard Murray, if I could, and I'm going to say the phrase of the year. Richard, you're on mute.
Thanks, of course. Preemptive, thank you. Look, appreciate that. I'll come to that, and I might just set up a couple of other things that I think are worth noting. Firstly, the point that I really like that Gillian made, which is that we need to make sure that today's medical and indeed our specialists and GP fellows must be literate in health systems science, the so-called third pillar. So we've had, you know, the foundation biological and social sciences, we've got the foundation clinical sciences, but this third pillar of expertise in health systems science, I think, is a really important point. We cannot have people developing leadership advocacy when they are illiterate in how health systems work in totality. Really proud about those developments at JCU. It's a big emphasis for us, and I think that's a very strong point. The second and related issue there, which is to do a little bit with the now, as Mr. Coulton was saying, is that to the extent that now is the time to seize the opportunity for health systems reform, a more joined up, if we are to have a health system that has a strong foundation or cornerstone of primary care, comprehensive, coordinated, multi-professional primary care that the population needs, articulating seamlessly with care and all being able to also be delivered in many cases by virtual means, then we really must pay attention to that. To do that takes one, knowledge of health system science. There's a whole research agenda for us, of course, in our partnerships, very important partnerships in northern Queensland with the Tropical Australian Academic Health Centre, TARC, an Academic Health Sciences Centre at NHMRC, recognised the notion that we can be a learning, innovative health system as a whole and train people for that purpose. So I think, and in which health services research, health services reform, health system science features very strongly, I think is becoming a real opportunity in a post-COVID world. So I think that's the health systems reform piece. I think the other piece is, and I'm noting that there's some questions about what's the difference between rural, remote, you know, etc., which of course, as anyone knows who's been around the traps for a while, there's no precise definitions, but you sort of know it in your bones, you know. But the other truth about that is that actually place-based planning, place-based partnerships, place-based integration must be a key feature of the future. Yes, there are things that we can say in general about towns of this sort of size and this sort of distance and this sort of location and this sort of population mix. Those generalizations have some value. Ultimately, how do the things get set up on the ground in the community between acute care, hospital care, primary care, rehabilitation services, evacuation, you know, mental health care and so on? How does that actually work? Needs place-based mechanisms. And that brings me really to the other setup point here, which I think is really critical, and that is how do we hold people to hold systems, including, and Ruth said, going through the motions. We have quite a lot of money put into the systems in the name of Aboriginal and Torres Strait Islander health, in the name of rural health. You know, you name it, there's plenty of dough goes in. How much accountability for actual outcomes is there? If you don't deliver, does that mean you need more investment or less? Actually, that's the dilemma for a funder. I know what my answer would be: pull the money off people who aren't doing the job, you know. And I think this sort of one of the opportunities, I think, is that when there is no money in health is about the only time you can get reform done, because our medical colleagues and others are way too powerful if you can buy them off till after the next election. When there's no money, you don't have that option, and policymakers have an imperative really of grasping the nettle of getting value for money. And actually, I think that rural can lead the agenda. And the prime example of that, primary care funding. We all think that we need to move to a system of blended payment, enrolment, voluntary patient enrolment, practice that looks after you, multi-professional comprehensive practice looks after you proactively, that also gets paid for things that you do as well as payment for enrolment, and you get a little bit of money for hitting targets or doing things that are of quality. And the whole world thinks that's the way we need to go. Can you do that on average for the whole country as a whole? Well, you might be waiting a long time. Death by incremental reform, or you can lead from the regions and get excellent models in place as an exemplar and then show how it's done. And I'd have to say, Northern Queensland uniquely placed as a natural health systems laboratory in health services, health workforce, health systems science, health funding reform. Why wouldn't we be in the front row of such things and be the proof, if you like, that might then be applied more enthusiastically elsewhere, because there's a living example. It's a bit like the medical program here is a living example. And so I guess I'd sort of offer that set of observations. Thanks.
Thanks, Richard. And I think we've all got quite good at reading the tea leaves during the COVID year, haven't we? So my tea leaf reading is that place-based education is going to be, or place-based solutions is going to be where we really want to be moving, don't we? And really having not that one size fits all for each community. It is different, and it is, we have to listen to the community and do it a bottom up rather than a top down. And so having support from state and feds to have a policy framework that supports that is absolutely. Yeah, Ian, we referenced TARC, and obviously a really important a development in Northern Australia. How do you see TARC contributing to and informing the next sort of decade or so around health reform, systems reform, the stuff that we're talking about, aligning undergrad, postgraduate?
I think that one of the pieces that TARC can add to is the tight integration, starting with research, what's called research, evaluation, research, assessment, and in Australia, our universities are separate to our health system or our hospital systems, and it's easier in a country where the universities own their hospital, and you can do trials where the notion of academic health centres came from. The organisational linking of the hospital and the primary care system, the PHNs, in with universities' intellectual leadership in a way, provides the platform that can take this forward. It's actually very difficult to do much of this stuff just from a university base itself or for a hospital base itself. And so I think that on the translation side of research and evaluation, innovation activity, these sort of partnerships are experimental as well, but backed by the Australian government, and have a reasonable chance of trialling, assessing, evaluating, and research methods for altering the fundamentals of how we deliver health services. And North Queensland's really good to do it, because there's lots of pet theories as to why places like North Queensland are ideal. But one of them is that you can quite often do this stuff best away from centres of industrial power and allow the system to evolve from there. I think the other thing that TARC will naturally lead to is, well, although it's starting with research, is it'll inevitably lead to studies around higher education and masters of this, and as people are actually studying and get used to thinking about questions on the ward and studying them and having mechanisms that make it easy to do, and it's part of your job. I mean, those are big cultural inhibitions at the moment, because our university and our health system pretty much run in parallel, sometimes at loggerheads. And it's very hard to do this without entangling them.
Yeah, thanks, Ian. And Minister Coulton, I might come to you there, because I think I remember when we were awarded the GP training contract at the end of 2015, we did feel like an in-place experiment, I have to say, with, take a punt. And I'd be interested in your comments and thoughts of, what Ian and Richard have said there.
Well, I'll pick up on what Ian said, the research component of it, and I think broadening out what rural medicine can be, and the fact that you can be at the cutting edge of doing research while you're actually working in your discipline. And so I think that's right. And Richard talked about some of the pushback you get for some of these reforms from certain bodies, and I'm a great believer in silver linings in difficult certain situations. And I think COVID has actually done regional Australia a great big favour. But there's things like, and I'm floating this one, I'll probably get shot from behind, but the fact that the supply of overseas students coming into Australia to study medicine, there may be an opportunity for some more CSPs for Australian students to go, because we are finding out there's enormous appetite for regional training. The Murray Medical School that we're just starting to get going in New South Wales and Victoria is having an enormous interest from young people wanting to study there. But having that broader cohort of people in the bush, so that you haven't got to go back to the city every time you want to do something. And so understanding that you do need a broader range of skills, from GPs to GPs that have procedural stability, to generalists and to specialists, but having training those specialists in the bush. Trying to I had an interesting discussion with the College of Surgeons last week here in Canberra about moving a lot of that out, so that we don't lose our people, because generally in that final point of training for your specialty is when you're making other life choices, that makes it difficult then to be as flexible in your movement around the country. So, and recognising that different jurisdictions work differently, and have been flexible enough as a federal government to be able to work on the strengths of the different states and still have a policy that's, so I guess, covering the entire country.
That's coherent, yeah. And Jalan, this is straight to you, because this is the big clash, isn't it? Yes, we all want more people to train out in the regions. Yes, we do. But where we work and live, it's Queensland Health that makes those decisions. It's rosters that drive, how many numbers here, there. And it is a huge barrier, I think, to all sorts of things. And Jalan, I'll give you a very concrete example of this. I'm looking, I can see the Townsville University Hospital outside of my office here. At the RMO level, there are about 90% of the doctors are Australian trained. At the consultant level, it is about 41%. And so to me, that is a stark illustration of a system that is not aligning. Sorry, you had no idea I was going to ask you that question, Jalan.
So Peter, and I'm going to be very UN on you now and go, what was the question?
The question is, it appears that there are within Queensland where we work, it's the Queens, because it's the Queensland Health, and rightly so, that have the contracts with the junior doctors and have to fill their rosters and so on. That idea of regional training, of specialist training, seems to somehow get very tangled and then doesn't deliver into the Australian trained or in Australian graduates working as consultants. And Richard, I probably made a bit of a pig's ear of that one. I don't know if you can articulate that any better. Still no question, Joanne. I still put a full stop at the end of that.
Yeah, I wasn't going to do that to you twice. So I can see Ruth's got her finger up. Do you want to jump in, Ruth?
Yeah, sorry. I was just going to say, look, I think the question is, so we have a distinct disjoint between the workforce needs of the hospitals and the future workforce needs of the nation. And at the moment, the workforce needs of the major hospitals are filled by registrars, which then feeds into a line of who will be, you know, what specialists we have. So this is why we have far more FACEM trainees than we have need of ASIM, you know, FACEMs. We don't need anywhere near as many emergency medicine consultants as we are currently training. We actually need far more consultant psychiatrists than we are currently training. And at the moment, we're lacking a mechanism to drive the to drive the numbers of training positions that are available. Any comments on that?
Yeah, so the whole thing has many moving parts, and I think that, you know, the first one is that Queensland Health has engaged to guarantee every graduate from Queensland medical schools an internship, so they'll get at least as far as being registered. That's our guarantee. Now, that created enormous pressure in the system for a short period of time. We went from having one medical school to 4 in pretty rapid succession. You know, I think it was 2000, then 2004, then 2005, that the 3 more modernly generated medical schools came online. And with that, the tsunami of interns and then JHOs. So the complexion, you know, the entire composition of the medical workforce shifted and changed. Combined with that, what I have seen is as you've alluded to, Peter Ann and Ruth, the drift towards specialisation and then super specialisation, or to use the more popular general practice term, partialisation. I think that what I'm seeing happening now in multiple fora is a usage of the term rural generalist in other disciplines. So one of the things I'm super excited about in Queensland at the moment is that we've generated rural generalist allied health training positions. You know, and a rural generalist allied health practitioner is an absolutely awesome contribution to a rural community where you couldn't possibly have one of everything. I've been having discussions recently with the clinical network leads of surgery and medicine about how we're going in the recruitment of people to their generalist training pathways, because we need general surgeons, we need general physicians. When I left Australia back in 2012, the general surgeon was really at risk, was at enormous risk, because everybody was becoming a colorectal surgeon or a something or other surgeon. But now that need for generalists is starting to be felt, and they are a much more suitable surgical selection for our regional hospitals. And I don't think the rural and regional discussion should be had separately, because the regional facilities, when well-resourced, well-developed, can become the hub that supports and enables the rural and the remote. Just as, you know, less remote can support remote, regional can support rural, and you kind of have a cascading, or even, you know, almost like Russian dolls. And I think that that development of a generalist workforce is desperately needed. That said, one of the things that I have really enjoyed observing as a difference in Queensland Health is the growth of diversity, because it's great to have international medical graduates working in our facilities, because they cover some of our weaknesses. you know, our community in Australia is a very diverse community. We are a community that's based, some of us on having been born in Australia, but many of us having immigrated here. We have whole communities, significant proportions for whom English is not a first language, yet medicine has never focused on multilingualism as a desirable strategy. We've just always assumed that we would use interpreters. And so, you know, like I love the fact that now when I walk amongst the clinical network chairs, it is no longer a gang of white guys who trained here. We've got diversity, and I think that that is a great strength. And I think that that balance is really great and is really what's needed. So,
sorry, I will have to just, fascinating points, we'll come back to it, just hold those thoughts. Minister Coulton, I know that you're on a very, very tight timeline. I just need to understand how tight it is.
Look, I've got 5 minutes. I've got I'm heading on a plane heading north, so I do have to be out of here. But I'll tell you what, I'm finding this fascinating, and you know, I'll just put a quick in that last point. We, you know, Greg Hunt and myself are looking at also, you know, some of that specialist training programs, understanding that we have a massive imbalance of the skills we need. At one stage, I think there was one geriatrician in Western New South Wales, and with an ageing population, you know, a GP with psychiatric skills. There's a whole range of possibilities, but you know, how far back into the career or the training pipeline of students, you know, do you try and encourage them to make those decisions? Because what we're hearing is that quite a lot of the influencers, while they're in those larger metropolitan hospitals, that are largely getting told, don't go bush, it'll kill your career. So maybe we need to keep them out of there in the first place, but that's just me. But yeah, no, I do have to go very soon.
No, and of course, one of our very experienced stalwarts of the bush, John Doyer, has been putting up some messages as we've been talking, and his point is we must stop talking about go back to the city as if we're assuming that that's where people come from, you know. And I agree, there is something about that. And the other thing I wanted to say, and we'll come back to you, Gillian, in a sec, is I meant to say this right at the beginning, a real shout out to people like John and others who I know online who have provided the transformative experiences to our undergrads and who have given them that mentorship and that view of the world, that vision that you can flourish as a practitioner and have a fabulous career, and you don't have to be working at the Royal St. whatever. You can actually be, in John's case, in Longreach. And I think we sometimes not forget, because we do think about them a lot, but all of this success is predicated on those people who are place-based, who are doing the work every day in those places. And you know, we have to remember that. So how many more minutes have we got of you, Minister Coulton?
Only a couple, I'm sorry to say, only a couple.
Okay, all right. Gillian, sorry, I cut right across you. Keep going.
That's okay, not a problem at all, because I'm really interested in listening to others as well. I think that there's work to do with the colleges, and it's great to hear Minister Coulton engaged with Greg Hunt, because we do need workforce planning. Where is the strategic workforce plan for healthcare, not just medicine, but healthcare in Australia? And how do we balance that with, you know, the market forces, the desires of the universities, and the needs and the willingness of funders to pay? I think that allowing more training in place that will allow people to put roots down and grow where they're planted, that's a really important principle. And I've personally been on the pointy end of trying to come back into the system, having been, you know, literally during my scholarship years when I was working in the more rural locations, having been working in and doing procedures on sick neonates, coming back to the tertiaries where I wasn't even allowed to prescribe Panadol without permission. We've got to get rid of that kind of geographic narcissism that where people assume that because you didn't learn to do it in a big capital city, your skills are not valid. So to sum up, I think we need strategic leadership on this, which is where I think we can really look to partnership with the federal government and the various learned colleges. And the states as employers really have to work we can sometimes feel quite powerless because of the college accreditation process. They're the ones who decide where the training places are. and that we kind of work around the edges. Now, so
I'm going to do again what I did to you 2 minutes ago, because I'm so sorry, because there is a question that's come in specifically for Minister Coulton. So
right, and that's it from me anyway. Don't come back again.
Oh no, you're fine. You're fine. We're enjoying it.
Minister Coulton, there's a question's come in. JCU are building a strong portfolio of evidence for the impact of regionally trained medical professionals. And the question's come through, what do you think about the implications for funding medical, what are the implications of that evidence for funding of medical education in Australia in the future?
Yeah, look, I think, we're actually, the federal government's actually moving that way. The Murray-Darling Medical School, where we are actually training people end to end and ultimately in their specialty. And I'm in fierce agreement with all this kind of discussion we've had at the moment. And so that's why we've also funded these trials to actually then look at more collaborative models for junior people to work in, multi-discipline teams where they're supported by more senior staff, but also at that time of the life, where you're going to get holiday pay or maternity leave, and you're not going to, we all know the days of someone going to town, buying a surgery and working 100 hours a week for the rest of their life is not there. And we also know that if you're going to replace someone that's been doing that, you're probably going to need 3 other people that want a life balance to come in and replace it. So understanding all of that, we are very much looking at where we can finesse our funding. We've got $550 million in a rural training program that we're rolling out at the moment, but having the flexibility to be able to adapt that to do the job is where we need to be. But I will have to sign off, and I found this really fascinating, and I'm looking forward to hitting the road next year. Richard Murray will know the last time I was in Townsville, I nearly got COVID from a senator, LNP senator. So it's a bit of a dangerous spot, a Chinese restaurant in Townsville with an infectious senator. But,
I remember we were demonstrating social distancing to you around that table. Do you remember that?
Yes. I met Professor Ronsky was at the same venue from memory. But I'm looking forward to getting back on the road. And in rural terms, after being locked up for a number of weeks, I was barking at the cattle grids on the way to town. I was that excited to be getting out of home. But looking forward to catching up. Thank you so much. Congratulations finally on your 20 years. That's just the start. The wearing the moniker of Trailblazer sits very, very lightly with you guys. And so congratulations. I look forward to catching up in face-to-face next year.
Thank you for your time and safe travels.
Thanks very much.
We might keep going a bit longer. I think there was some, sorry, Jolanne, I feel incredibly rude, and I feel like my future employment with you is at risk. But I think, just to summarize, and we'll open up to the panel, I think you have this extraordinary lived experience of it, as well as now, also being in policy positions or positions of policy influence. You mentioned about the strategic leadership, the workforce reform piece. Do you think, how far away do you think we are from this actually now being realized?
I think that there's still a significant issue, but I'm hopeful. I'm usually optimistic, just that's a trait. But I do think that with the increased engagement and the establishment of the National Cabinet, there's a chance, because one of the problems in the system is, just like the funding model is split, workforce is split, because the learned colleges tend to have their relationship with the federal government. We deal with the state branches, but the training places are farmed out into the state healthcare system, which, as Ruth said before, a whole lot of that is a result of workforce need. We've got to run the hospitals, and we've not done well, as some other jurisdictions in the world have done, even in Australia, of generating, career medical officers who stay in place in the hospitals and free up, therefore, training to happen directly in the place where it might need to be. So if you think about how different the world would be if we didn't rely on PGY 1s, 2s and 3s and a raft of IMGs just to keep the lights on in our major hospitals, but that we could more intentionally train them for what it is that they need to do, the world might be quite different. So I find it hard to say we're going to nail this because of that federal state divide and the fact that nobody has clear responsibility around workforce planning, workforce placement, the oversight, the churning out, and then how on earth do you make sure that people work where you want them to, other than pour resource into, as you have done, as this really innovative medical school has done. It's going to be a tough nut to crack, but in the national interest, we're going to have to, and I hope we get to it before we're at desperation point.
Thank you. I see everyone taking themselves off mute. Ian, you go first.
And I think, so I agree entirely with that. And can I add another obstacle? The Federation White Paper was defeated. Part of the background to that was the reorganisation of the health system and the higher education system to try to rationalise them across state and fed. So the politics of that are still relatively recent. And so I think one thing that did come out of COVID was the National Cabinet, and at least for a while, a willingness to meet and do sensible stuff mostly. Still, there was still a fair bit of not sensible stuff out of the National Cabinet, and that suggests that politics still plays a role. Regional politics or local politics can still play a difficult role. But we're going to have to find ways of cleverly working around it in areas that are sort of case studies and implement it and then allow it to osmose into the rest of the system. And that sort of is how a lot of policy gets done in Australia, because we're spread and diverse and we like to fight. So I think one of the way forward to me would be, what about people get their heads together and think of 2, 3 or 4 case studies that we could have a go at fixing and targeting just those things, and then see how we could take it forward. My sense is if we go for the full Monty, we won't get as far as we hope.
Thank you. Astute observation. We've got a question that John just wants to give from the audience, and then Ruth will come to you, and we'll aim to close in about the next 5 minutes or so.
Thanks, Peter Ann. This question might be focused at Richard or Ian. Gillian's just spoken about the workforce need, and we've been speaking about the post-graduation issues that complicate specialist training and maybe contribute to the maldistribution of specialist training. The question is, what role does undergraduate medical education play in addressing that problem from our end?
Such a good question. Look, I think it's that point that I think Minister Coulton made, Ian made too, that these are human beings who are not only undergoing a formal education and training process, but around whom a deep and rich hidden curriculum is operating. Who are the heroes? Who are the losers? What does success look like? Who do I admire? Oftentimes that's people who may be near peers, folk who are 2 or 3 or 4 years ahead of where you're up to, and you think, gee, I wouldn't mind being half as good as what they are, and isn't what they're doing fantastic? So I think some of our success has been providing exposures, assisted too, I have to say, by the things like the Rural Student Club and so on, to people across a continuum who've been able to influence in a line almost, and that includes some of our old growth, if you like, rural doctors, the sort of heroic, sort of iconic people, as well as those who are just a few years ahead and who look like they're doing exciting and interesting stuff and are involved in the education, teaching, supervision, and the social milieu. So I think we should I think we've done that pretty well. I think we could do it better. One of the big structural things that's missing is, of course, in the general practice training system, a student will get exposed to just about every other sort of registrar, except a general practice registrar. So they'll meet the emergency registrar, and they'll meet, and it is a weakness of our system that, because of the way in which GP registrars are funded, which is essentially the Medicare turnstile, the opportunity for them to be involved more substantially in the supervision teaching of juniors is limited compared to other specialties. That's a structural gap. Mm. If I might, though, because we're going to close, I reckon we should really make a pitch to Ian's point for this region to be on the front in a blended payment, a voluntary enrolment opt-in system for general practice, linked to a population-based funding for regional hospitals, admission avoidance, hospital and home, and all the rest. We would do that really well. We know each other, and I think it could be nationally and internationally significant.
And Sandra Caulfield's busy on chat, just giving us the framework for it. So Ruth, we're going to go to you, National Rural Health Commissioner, to bring us into close, please. No pressure, no pressure, Ruth.
Yeah,
but make it good.
Okay, so I've got some good news. Everywhere I've been going and talking about the problems as Gillian described them, or that we get a system that follows the funding. Everywhere I go and suggest that, therefore, if the system isn't serving rural and remote communities, then perhaps the funding of health care for rural and remote communities should change. Everywhere I go, people agree with that. And I am also increasingly finding regions that want to have a go at trialling a different model. So there are a number of regions that I know there's quite a bit of work being done, but they're not public announcements, so I can't actually alert you to that, but the work is happening.
This is just between
Come
us.
on, you're amongst friends here, Ruth. We don't have hundreds of people online. Just go for it.
Yeah, just,
Not at all. No.
We're not recording. No.
We're not recording either. No, but I think what you're saying is there's a moment in time, there's an alignment of leadership, there's an alignment of policy. There are, JCU Med School has matured to this point and is now ready to go further. So look, I just wanted to thank everybody so much, all the people online, people who've given questions, and of course the wonderful panelists. It's been an absolutely marvelous. Joanna, I will be coming to talk to you afterwards. But a great discussion. Thank you, everyone, and enjoy the rest of your afternoon. Cheers.
Very much, everyone.